So we're back, still talking about general and local anesthetics. Next, let's talk about neuromuscular blocking drugs. You may hear them called neuromuscular blocking agents, and they're also known as NMBDs. What they do is prevent nerve transmission to certain muscles, resulting in muscle paralysis. So these are used with anesthetics during surgery. When they're used during surgery, artificial mechanical ventilation is required because these drugs paralyze the respiratory and the skeletal muscles. The patient cannot breathe on their own. They do not, however, cause sedation or pain relief. The patient may be paralyzed and yet conscious. So we will see these in some other areas, for example, with mechanical ventilation for other purposes outside of surgery. But always we're going to make sure that mechanical ventilation is provided. So our neuromuscular blocking drugs fall into two categories, depolarizing drugs and the non-depolarizing drugs. In the non-depolarizing drugs, we have short-acting, intermediate-acting, and long-acting. Our most significant depolarizing neuromuscular blocking drug is that succinylcholine, and this works similarly to the neurotransmitter acetylcholine. Notice they end in the choline. What it does is it causes depolarization. So metabolism is slower than acetylcholine. Now, let's back up for a minute to acetylcholine. Remember, it's a small molecule neurotransmitter, and it's different than the other small molecule neurotransmitters in that the postsynaptic action of acetylcholine at the cholinergic synapses, that neuromuscular junction in particular, is not terminated by the reuptake of the acetylcholine, but by that hydrolytic enzyme. You remember it as acetylcholinesterase, right? So this enzyme is concentrated in the synaptic cleft, ensuring a rapid decrease in the acetylcholine concentration after it is released from the presynaptic terminal. Acetylcholine has a pretty high catalytic activity, and because of that, it hydrolyzes and it moves very quickly. Well, the metabolism of the succinylcholine is very slow, or much slower than the acetylcholine. So as long as the succinylcholine is present, the repolarization with the acetylcholine cannot occur. So what we have here as a result is a flaccid muscle paralysis. Now, our non-polarizing drugs, the non-polarizing neuromuscular blockers, our short-acting one is our mivacron or mivacurium. Our intermediate-acting atracurium, vicuronium, rocuronium. Look at these and notice that the suffixes are similar or almost or identical. So these are non-depolarizing drugs. These are medications that are going to be given in a specialty, by a specialty personnel. And what they do is they prevent the acetylcholine from acting at the neuromuscular junction. So this nerve cell membrane is not depolarized, muscle fibers are not stimulated, and the skeletal muscle contraction cannot occur. The first sensation is going to be muscle weakness, followed by a total flaccid paralysis. The small, rapidly movable muscles, such as your fingers and your eyelids, will start, and then the limbs, then the neck, then the trunk. So it goes from the outside in. And finally, the intercostal muscles in the diaphragm are affected, and that results in a cessation of respiration. So ventilation, right? Ventilation, ventilation, ventilation. Recovery of the muscular activity usually occurs in the reverse order. So transient muscle fasciculations can sometimes result in later muscle soreness. They're going to feel like they've been worked over. The neuromuscular blocking drugs indication, their main use is to facilitate the controlled ventilation during surgical procedures. We also use it for endotracheal intubation. That's a very short-acting one. We'll use them to reduce muscle contraction in an area that needs surgery. It's also diagnostically used for uh, diagnosing myasthenia gravis. There are other uses, but those are the ones that we will see the most commonly used for. The NMBDs have few adverse effects when they're used appropriately. They can cause hypotension because of the blockade of the autonomic ganglia. They can cause tachycardia since there's blocking of the muscarinic receptors, and the hypotension also results as a release of histamine. So effects are always going to vary according to the site. The number one safety issue with these drugs is that respiratory muscle paralysis occurs. So emergency ventilation equipment must be immediately available. A neuromuscular blocking drug overdose causes prolonged paralysis, requiring then prolonged mechanical ventilation. Cardiovascular collapse can occur. There are several conditions that may increase our sensitivity to the neuromuscular blocking drugs. You will find a list of these conditions in box 11.4 of your textbook, so I would recommend that you check out that box. Our nursing implications for all the anesthetics, the general anesthetics as well as the neuromuscular blocking drugs, include that we always assess the past history of surgeries and the response to anesthesia. Don't forget to ask about the family history of malignant hyperthermia, because we know it does tend to run in families. Assess their past history, their allergies, their medications, use of alcohol, illicit drugs, or opioids. Don't forget medications that are over the counter as well as herbal. We've been discussing the perioperative patient, and assessment is vital during all the areas, right? The preoperative, the intraoperative, and the postoperative phase. Vital signs are going to be done more frequently. We're going to have those baseline labs and other tests that we talked about, EKGs, maybe a chest x-ray. Oxygen saturation is typically monitored consistently, and airway, breathing, and circulation. We're going to monitor all of the body systems, though. We want to make sure that kidneys are working, functioning, liver, and that the patient is kept safe. Remember, each perioperative phase has its own complex and very specific nursing actions, so make sure that you understand and follow your facility policies regarding which the perioperative stage you're taking care of the patient during. Provide preoperative teaching about the surgical procedure and the anesthesia. Remember, your patient isn't going to be in a position to understand or to follow up on teaching in the immediate postoperative stage, or obviously not during the intraoperative stage. So anesthesia, general local anesthesia, always requires close and frequent observation of the patient and all the body symptoms. And we're going to watch for those sudden elevations in body temperature, because that can indicate the malignant hyperthermia. Malignant hyperthermia can occur postoperatively. During that post-op recovery phase, they're also going to monitor for cardiovascular depression, respiratory depression, and any other complications of anesthesia. Implement safety measures during the recovery, especially if motor or sensory loss occurs because of a local anesthesia. Reorient your patient to his or her surroundings. Sometimes people will be aggressive when they come out of anesthesia, especially children. And so don't be surprised by that. It's not personal, it's simply they're disoriented, and that is their reaction. We want to teach the patient about the postoperative turn, cough, deep breathing, all of those things that they're going to need to do or not do. Sometimes the turn, cough, and deep breathe, or the turn and cough, is sometimes contraindicated. So that's why I want to teach the patient about that preoperatively. Obviously, in an emergency situation, we're going to do that postoperatively, and we're going to do it repeatedly. So it's really in the initial stage, not teaching as much as instructing, and then later you're going to make sure that they understand what they need to do when they go home. As always, you know how to get a hold of me. Email, text, give me a call, post it in the discussion forum. I look forward to talking to you soon.